Good morning, friends. I thank Dr. Ashok Shroff for giving me this opportunity to share my views on this very important topic. As already previous speakers have highlighted, that what we want, all of us, after cataract surgery is youthful, unaberrated optical quality. Our vision should be as we were young, and there should be no aberrations, and the optical quality should be good. When we highlight optical quality, that means what we are talking about is not only near and distant Snellen's acuity, but it should be excellent modulation transfer function. There should be good contrast sensitivity and free from photopic phenomena. So we'll be dealing with all of them. Options we have in the multifocal is refractive, then diffractive, which may be apodized, and new lenses are coming, which is intermediate. And of course, accommodative will be dealt by Dr. Rajiv Chaudhary. So the refractive multifocals which came, it had a 5 progressive, 1, 2, 3, 4, 5. And this was the little modification of the same. This is silicon, this is acrylic, and little you can see the much sharper edges. These are softened to reduce the optical phenomena. Distance was 2.1 millimeter, and the second ring was at 3.4 millimeter for near. And in between it was blended for the intermediate vision. So this was totally pupil dependent, because for a near vision you need to have 3.4 millimeter pupillary diameter, only then it will be effective. That was the reason most of the Indian patients, old patients, have got a very small pupil and they will not gain much, and there is a pupillary constrictions while reading and in a bright light. So they may have a reasonably good vision. So when we started doing these lenses, video? Okay. So the blended area gives 13% for the intermediate. It is a distance dominant 50% and 37% near. It had an add of 3.5 diopter at the IOL, which gives around 2.5 diopter at a spectral plane. The advantage of this was it gives around 40 centimeter, 50 centimeter. It was supposed to be a very good lens for intermediate vision, so that patient who are working on a computer or at that distance, it usually used to work very well. And if you are doing a biometry, it should be little on the plus side to reduce the halogen glare in this patient. We have put these lenses as a part of a thesis topic, and many patients who had a smaller pupil, we actually did a sphincterotomies 8 or 10 to have them the near vision corrected. So you can do that. But these lenses have gone out of favor because of the much more halos and glares, and now the lenses which are very good are a diffractive multifocal. They work on a principle, Huygens Fresnel principle, and I don't know, some of you might have used those who have got a high myope numbers. They used to come a film of -6 diopter and the lens thickness is decreased. So what it does, there are steps over here, and this is a base curve. So the base curve decides the power of the lens, and the height and angle of this step will decide near and distance and how much light distribution you want to do. You have got a choice. You want to have more for near, you want to have more for distance, you want to increase the gap between the two. All can be adjusted by the design of this. So that means you can have a +4, you can have a +3, you can have +1.5. All this is very well possible, because every circle gives you for near and distance, so they are not pupil dependent, because the circle starts from 1 millimeter itself. So the advantage of this is the modification is possible. Like we had an accurate twin lens which we used as a part of thesis. In one eye it was 70% light was for the distance, 30% for the near. In the another eye there was 20% for the near, 30% for distance, and patients are really very happy, because both the places when they are reading for near, this eye becomes a dominant and blends with this when they are for distance. So both the things can be done. Then thickness, initially we had a silicon optics, now we are available in a thickness. And then Restore came with the apodized optics. As I was talking to you, that depends upon the height and angle of the steps, which decides how much light can be given. Because what they found out was that in the like in the techniques it gives +4, and the 25 centimeter of reading distance is not very comfortable, but those who do a lot of reading work, the architect will be very, very happy with that vision. So most of us need more vision for distance. So what they actually did was, these steps, as we keep on going to the periphery, were decreased in height, so that more light is available for the distance than for the near. So initial few circles will give you a reasonably near vision, and after this, because whenever you are reading, your pupil will not be dilated so much, so after 3.4 millimeter or so, it is totally for distance. So when you are driving at the night, you are going a movie to improve the contrast, so peripheral part was totally kept for the distance, only intermediate zone was used for the near. So now let's see whether these really work well or not. This was a very well conducted trial of 566. This story we can take as a prototype for defective multifocal and 194 monofocals, and they were assessed for visual acuity, quality of life, optical phenomena, and night driving. So if you see the binocular uncorrected near visual acuity vis-a-vis monofocal versus the multifocal, there is a gross difference, though for distance it is more or less same. So all the multifocal patients did far better for near vision. So they work well for near and distance. Do they compromise on the quality of life? So spectral freedom was achieved for 80% of the patients. When they thought of the patient's satisfaction scale, out of the 10, multifocal was liked by 8.7%, while the monofocal by 4.2% of the people over there. Their satisfaction level was at that level, not number of percentage. So if we look at the biggest drawback of this multifocal lens is visual disturbances, halos and glare. And we need to understand that many patients of monofocal also complain of halos and glare. Well, this is not a talk on halos and glare, why it happens, but all the patients who have got such a thin lens, it has got its own optical phenomena, S phenomena, so there are a lot of things. So if you compare this with the multifocal lenses, had far more, you can see over here, and this you see the monofocal. So if you see the monofocal had very few glare and halos. This is the night vision, this is halos, this is glare, while multifocal had far more. This is around 25-26%, while this is 7%, 5%. So there is definitely increase in the glare and halos. And contrast sensitivity was thought to be affected much, but it was not affected in these cases because of the apodize optics, but the contrast is definitely low. In our own study we found the contrast actually goes down by 1 line or so. 3 letters contrast is definitely down. And if we see the night driving, so they have got a night driving simulator where the patient sits on a machine and they try to find out if the visibility and the visibility distance for road and hazard signs was checked. In a normal visibility condition, there was no difference. But in a rural area under fog, there was a 15% decrease in a distance where they can identify the hazard signs or the road signs. While in a city street under glare, there was a marked reduce of the distance when you can see the signboards and the hazard signs or the road signs, whether you want to turn right or left, to nearly 28% in a glare condition. But in a normal condition, there is no glare, it was perfectly alright. So there are a lot of adverse events. When we looked into the IUL replacement was done out of the 566, 7 patients were done, but 1 was because of the visual disturbance. But other 2 were because of the biometry error, 2 were because of the operating error, 1 was because of the trauma, and 1 was the dissatisfaction of the patient. So because of the visual disturbance, it was only 1. And biometry error, of course, is quite common if you are not very careful. With the coming of the IUL master and all, the biometry has definitely improved a lot as compared to the ultrasonic biometry. So we should always give the option to the patient, otherwise the patient will come and complain, I was never told that, and how you thought I can't afford it. So we give the option to the patient, and before we give the option to the patient, we have to find out whether, I defined it fine and a gross work. So whether reading, architecture, drawing, they'll be happy with the Technics type of a lenses, which gives far better near vision. If they've got a gross work, they'll be happy with the +3.8, like a Restore 3, which will be far better for them. And we describe the option to the patient. We ask them whether you want to have a standard cataract surgery, and we explain them what does that means. Does not correct astigmatism. Eyeglasses will need to be worn for most of the time. if you go for what we call as a refractive cataract surgery, you'll be able to read newspapers, you'll be able to pass the driving test, and you'll be free of glasses for most of the time. We don't say all the time you'll be free of the glasses. And if patient has got a corneal astigmatism, we need to explain them, I understand corneal astigmatism, so whether you want to go for a standard cataract surgery same way, and we explain them, if you go for a standard cataract surgery, your cylindrical will be left. And same as we made a chart, if you want to have a standard astigmatism correcting cataract surgery, we go for a toric IOL. You want to have astigmatic correcting refractive cataract surgery, toric with multifocal IOL. So all these 5 options are given to the patients to decide what he wants to go for. And the newer designs are definitely going to make it far better. If you see the multi-order diffractive, one is the intermediate, already this study is going on, the Spain, like the rings you make, one for the near, one for the distance, another ring you can make, one for the distance, another for the intermediate, so that you can select these heights and you can have some of the light going for the intermediate distance. So you can have a 1.5 add, you can have a 3 addition, and you can also have a distance, so that patient can see for all the distances, and the results are very, very encouraging for this lens. And then now we need to refine these optics further. And a conventional diffractive lenses, there are little more disturbances of the colors, because all these rays, red, green, blue, yellow, have got a different refractive index. So they focus at a different point. In a multi-order, the heights can be adjusted in such a way that all the rays will focus at one point and will give a sharp vision. So this is about to be made. And thank you very much for your kind attention.